Welcome to Eurofins Viracor Clinical Diagnostics Podcast, where I'll be sharing up-to-date scientific advances, key diagnostic testing, and our most recent innovations. This is our aim is to connect with transplant professionals at this event while always staying patient-focused. Our aim is interviews aren't limited to any one profession. A diverse so whether you're a physician, lab director, transplant coordinator, patients, and even doctors or even the patient, also recipients, we would love to hear your voice. If you'd like to be a guest on our show, you can amplify your influence and tell your story. Summary on Amplify your influence on Transplant Radio. Enjoy episode 15 of our 15-part series.
Good afternoon. Welcome to Transplant Radio, Amplify Your Voice. This is Kevin Foth, World Transplant Congress 2025 in sunny San Francisco, day 4 of the event, and we're lucky to have two stellar guests this afternoon to wrap up our Tuesday. Going to start first on my far left. We have Dr. Taylor Held Sargent, who is a pediatric infectious disease physician focusing on viral-based infectious diseases. Sitting sandwiched comfortably between us and not looking nervous at all is our good friend Dr. Daniel Friedman. Daniel is an ID doc, focusing more on fungal diseases. You all that are listening may know the name. Dr. Friedman did a webinar for us, we'll just call it a couple of months ago. Was absolutely terrified about it, but I tell you what, he did a fantastic, phenomenal job, and we're glad to have him do that. So that's why we invited him back, and he roped his support person in. And Taylor, so we'll see how we go. We want to talk about infectious diseases post-transplant. You both have worked in pediatrics. I think Taylor's done a little bit more than Daniel has. And then we'll just kind of talk about that. So give the audience, and we'll start with Taylor first, how you got to where you are today. What were your influences that decided that carried you to this path in your life of pediatric infectious diseases?
Okay, so I think we have about an hour for me to discuss this, right?
We've got however long you want to talk.
So going back to the late 1900s, just kidding, I'm not that old, although I am, but we're going to ignore that part. So actually when I was in undergraduate, I did a summer rotation in a pediatric infectious disease lab that was studying herpes viruses. And that summer I had a lot of fun because the product I was looking at worked, which it's like gambling. You should never win the first time because then you're hooked for your whole life. And I walked out of that summer experience saying, I want to have that job. I want to do pediatric infectious disease research, and I just kept going. So I ended up getting my MD and my PhD, and I did research in coronaviruses, the OG, original SARS-CoV-2, or not, so it wasn't 2 at that point, it was just SARS-CoV. And then I went on in my fellowship to look at herpes viruses, and that was where I fell in love with transplantation. And so I got interested in CMV specifically, and when I became an attending, I am now a transplant-focused pediatric infectious disease attending, which my husband does not know how I can just keep finding ways to get more and more specialized, but I somehow have done it, and now I really focus a lot on the solid organ transplant patients.
So I've got a bit of a strange question.
Okay.
You've got your MD.
Yeah.
You've got your PhD.
Yes.
So do we have to say doctor? Or just one doctor take care of it?
One is fine.
Okay.
But yeah, I've just means I went to a long time of school.
So I actually got my master's during residency, and I do
We're not talking to you yet, Daniel.
But I like people to call me Master Friedman MD.
Oh.
So you can do that.
Okay, no doctor, just doctor, but master doctor sitting next to me. Okay. So let's talk a little bit about the differences of the therapies, the differential diagnostics, and like this. It takes you, we'll start with, we'll let Daniel start first. Well, I guess Daniel needs to introduce himself first. Master Dr. Daniel.
I, first of all, have now known Taylor for a few years, and I didn't really know this journey. So you're not only stretching our influence out to the world, you're bringing us closer as colleagues and friends. So thank you for that.
I don't like people to know the double doctor part. It's kind of embarrassing because it shows how old I am.
I originally am from Canada, and I did all my training, my medical school in Canada, in Alberta, and I don't actually remember why or when I wanted to do infectious diseases. I actually initially wanted to be a surgeon, and then I wanted to be a pediatrician. I did all my electives in pediatrics, and the month before I was like, I like adults better. And so I went into internal medicine and realized that infectious disease people were just the smartest people in the hospital, and I wanted to be like them. And then I got matched when I wanted to do more shadowing and research with some transplant ID doctors, Karen Doucette and Carlos Cervera, and they opened the door to me, and I couldn't imagine doing anything but this job. It's, I think, as you said, how I tumbled into this sort of subspecialty, I couldn't imagine myself not doing ID, and within ID, I couldn't picture not seeing transplant patients and working with the transplant teams. For me, that's the most fun part of it, is getting to, I don't feel like I'm managing a patient alone. I'm giving an opinion to coordinators, surgeons, primary physicians, and it's very team-based, which in medicine, especially in 2025, we often forget. So that's how I got here. I think I'm more clinical, and I'm very impressionable. So I just happened to work with people who are more in the fungal space, and I got really interested in fungi and worked with people in the mycobacterial space. So I like mycobacteria. Viruses, not for me, but I'm glad, because that's what Taylor does. So between the two of us, we have the north side and the south side of Chicago covered. We have you covered from birth to death. We got viruses, fungi, bacteria covered. And one with a good sense of humor, Taylor, and one with a dirty mouth. So.
Well, we hope we don't experience the dirty mouth part. We will be happy to laugh at mom jokes from Taylor.
We'll do mom and dad jokes.
Well, both of you, very remarkable individuals, and don't sell yourself short saying that you're so old and you spent all this time in school. I'm looking at both of you. You're youngsters in my eyes, so kudos to you guys for doing everything that you've done, everything that you continue to do, and your advocacy and outreach for transplantation and transplant patients. Is there any particular form of transplant that you focus on a specific organ like that, Taylor? Then we'll ask Daniel.
So, no, I'm organ agnostic. At Lurie, we do heart transplants, kidney transplant, liver transplant, and intestinal transplant. We're not a lung center, not a pancreas center, but out of those, we do a fair number of pediatric heart transplants, and so that's the group that I've gotten to know very well, and I find quite interesting because immunologically, their immune systems can be sometimes the most susceptible to infections. So I have to really be there with them a lot of times, unfortunately, because they do get more infections than some of our other solid organ transplant patients. And I love all the people I work with, but I have gotten to know our heart transplant team really well. As Daniel said, this really is a team sport, and I love all of my colleagues and love working with them. And then I also have gotten involved with a group called Transplant Families, and that is a group of parents and recipients of solid organ transplants and some stem cells. And a lot of the organizers in that group are also heart transplant recipient parents. So another thing that's tied me more into that population. But I really work with all of them. I see all of them in clinic. I think and when I get home, I have 2 different organs that I'm seeing on Thursday morning. So.
Wow. All right, Daniel, your turn.
So similar to Taylor, I'm organ agnostic, as she said. We also, so at University of Chicago for adults, we do all solid organs except for intestines, and we do, of course, as I think they do at Lurie's, we do all like modalities of bone marrow transplantation and CAR T, and so we are involved in all of that. I don't really have a favorite because I love fungal infections, and fungi are really sloppy and will go after anybody, and so I get to see my favorite types of infections in all organs. I think similar to Taylor, we have a pretty booming heart transplant program at University of Chicago, and especially because we do a lot of combination, like multi-organs, and we do a lot of transplants for patients who don't accept blood, like those who are Jehovah's Witness. So we get a really big, I would say, influx of people from outside of Chicago, from even outside the US. And so I just love working with all different patients from all these different interesting backgrounds with all these different exposures. I'm pretty social, and so when I think about the groups that I like working with, it's usually the people in the groups that I really just like being around. And I could think of people in every group that I call upon. So I don't have, this is all to say, I like everyone, and I like all organs, except for intestinal transplants that we don't see at Chicago, but I think if they came, I would love them just as much as anyone else.
They're a challenge, I'll warn you.
When Taylor gets them to adulthood and I see them at University of Chicago, I will welcome them with open arms.
Very good, very good. So we've learned that you're organ agnostic, that's fine. What about organism? Are you organism agnostic? What's your favorite virus that you like to see and to work with in the way of therapy?
I don't want any of my patients to get infected. One of my favorite things that I do actually is I do a lot of pre and post transplant counseling about, you got a new organ, how can you live your life? We want you to live your life with this organ. And so we go through every aspect of their life. I joke that I'm house, because if I could come home with them and just look around, I would. And now with telemedicine, I sometimes pretty much can. And I can see how does their family function? What do they value? Where do they like to go? And then tease out the scary infectious risks that they have there, and how they can continue to do what they love, but minimizing some of those infectious risks. With that all said, if they do get something, I'd say I'm a virologist at heart, so I love thinking about viral infections much more than bacterial infections. So that's what I gravitate towards managing, especially cytomegalovirus. That was a focus of my fellowship work. So I do, and unfortunately we still see that a fair amount in our patients. So that's probably where I would land if I had to choose favorites.
So how do you feel about the moniker that CMV has gotten of the troll under the bridge?
So the troll of transplantation, I was just joking about that a couple of days ago with some adult ID, and they're like, it's not anymore, CMV's not that bad. It's like, but that gives me an excuse to discuss fairy tales. In any lecture that I do, which as a pediatrician, I have to have some sort of theme for my presentations, and what better than bringing up fairy tales? So I don't mind it, because then I get to talk about the Billy Groat's gruff.
Well, but if you take it from scary to not so scary, I think people will listen better.
Yeah.
And pay more attention and absorb and internalize that message you've got.
Yeah, and we certainly have more tools. Why my colleagues were saying that it was not the troll anymore, because when that moniker came out, I think there was a lot fewer things that we could do diagnostically and therapeutically. And now we have a lot more options, and it feels good to be able to tell our patients when I go in and see them, here's the diagnostic uncertainty, here's where I think we should consider treatment, and here are my second and thirds if it doesn't go well, which is a nice position to be in now.
So what have you seen in the evolution of antiviral resistance specific with CMV?
Yeah, that's a big fear that we have. it's something we're always thinking about, always testing. It's a challenge to know when to send the testing to start with and when to consider, is this resistance or is this just a teenager hiding the pills under their bed, which unfortunately can happen in our population. But having the multiple agents as our backup, we had a patient who had a terrible course of multi-year just developing resistance after different resistance mutation, knocking out the different classes we could use. In the end, we were able to get her through it, and she's thriving now. It's incredible, and I get to see pictures of her in her Halloween costume every year, and I just love pediatrics for that reason.
All right. We've learned about Taylor and her troll. Daniel?
Do you want me to stick with viruses or go to fungus?
No, fungi.
Okay,
I'm a mycologist, mycobacteriologist. That's how we first met, was at it.
Good. I was like, because I don't...
Mycology conference. So.
I don't think I'd have enough to say about viruses. But, so I'll say outside the body, I love all molds. I love seeing them in the lab under the microscope and how they grow. And I pulled it up because this is my favorite one, is, I can never pronounce it, but Coccuromyces. I think the stain of it is just, it's art. Like, this is, if you could get me a print of this, it would go on every wall in my house because they're just so beautiful. I think one of the infections that I've come to respect, especially when I moved to Chicago, is histoplasmosis, and we see quite a bit of it in Chicago, both in our transplant and non-transplant patients. And that's the one where I always... with all fungal infections, it's never a straightforward, not everyone is the same. How we would approach diagnostics and treatments are different. But histoplasmosis, every time I think I understand it, or I think that I am doing the right thing for the patient, there's just a wrench that gets thrown in the wheel of things, and I learn something new. And I like those, again, I like connecting with people, and I feel like with histoplasmosis and other endemic mycoses or other mold infections as compared to like Candida, I get to follow these patients for a long time, and with histo, I will say for the most time I get to see them improve, and so I get to see people at their worst get to their best, and it's always a bumpy ride in between that's never the same between people. So I think if I had to pick histo is my go-to.
Okay, so what are your thoughts about the slightly polarizing differentiation that's going on now between endemic mycoses and dimorphic mycoses? Because, endemic, historically, it was always thought histo exists here in the Ohio River Valley. Coxio exists here in the Arizona region. Blasto exists here in the Mississippi area. Crypto is more Northern California. You got all paracoccidioides and the new, used to be a penicillium, but now it's tachylaria. Can't say it right now, but what do you think about that emergence of going from endemic to dimorphics?
So I said endemic, and I immediately felt like this was going to come up because it's such a, as you heard at our last fungal meeting, that it is controversial because, I think, as you said, with global warming, with a lot better understanding of fungi from a molecular sort of genetic standpoint, and all these very advanced tests that we have, we're discovering that different fungi are actually the same, and that different fungi that we thought were maybe only in a certain place, we can now detect them by alternative methods. We're seeing patients, I see patients who come for transplant evaluation, and if they for whatever reason had a cocci serology sent off, and the patient comes from the Middle East and maybe has never been to that area, and it's really, I used to say that's nothing, but the more that I'm seeing it, and the more I've seen people with what I determine as true positives, does make me question what endemic means. The other thing is that we think of endemic and dimorphic as interchangeable, but we know that fungi like Cryptococcus, which is a monomorphic yeast, is endemic. And so, especially in literature, especially when we're talking amongst ourselves and having purist definitions, calling, histoplasma as a endemic mycoses might not be the most appropriate that we see it in more places. So I think this is all to say, know what you're talking about, but don't be blinded by those rigid maps that we're seeing are much fuzzier and are just like the molds themselves and are growing outwards. Maybe I wouldn't have histo at the top of my differential for somebody from northern Canada. I saw lots of patients when I practiced in Edmonton, but maybe if my classic diagnostic workup is not making sense, not think about endemic as the barrier to getting to the diagnosis of truth. So I think that we need to relax on the term, be very explicit on what we're trying to talk about, and have an open mind as we understand more about these fungi.
Very good, thank you. So, but thinking also about globalization.
Yeah.
You can jump on a plane, you could be in another country, you could be 3/4 the way across the world in just a matter of hours. Are you seeing that the same way with viruses, Taylor?
Well, I think the pandemic proved that pretty well. It goes everywhere. And not just viruses. As we were talking, I was thinking back to, you asked favorite infections. One of my favorite diagnoses that I made, I can't take credit for, but it was something that's only seen usually because of the vector in the west coast of the country, of the US. But we had a patient who happened to travel there. We didn't know that at the time. And we just got the history from a pediatrician about the symptoms, and my attending said, any chance she was just in Northern California?
Right.
And the pediatrician thought we were wizards and was like, oh my gosh, this started when she was in a cabin in Northern California. You're right. But she had flown back a month and a half ago, and it ended up being a spirochete, which was beautiful under the microscope, because it's one of those corkscrew that just spin around, and the CDC grew it and sent us the video, which I was a first-year fellow, and it was just amazing and solidified my joy. And people still joke about how I literally jumped around the office that day. But it's things like that where luckily my attending was thinking about it, because we didn't get the history that she had been in Northern California. He had to think to ask that question. And when I went on the CDC website, it didn't even include any states on the map. Like, the map was only the western half of the US, and it was only highlighted along the coast. Like, our state wasn't even on the map of potentially having that pathogen. Right. But we had to think about it. And now with the spread of vectors, with weather pattern changes, we definitely have to think about even the vector-borne diseases, not just the viruses that can hop on the airplane, but the ticks that are spreading across our country.
Mm-hmm. Exactly. That's really an interesting story. It just changes the whole, I want to say, history of basic differential diagnoses and such. And thinking back, I know I've done it, my wife has done it, I've got several friends that have done it too. You're going to see the doctor. I was like, why is this stupid history form so blasted long?
Yes.
Well, there's a reason why. Where have you been? What have you done? What have you been exposed to? Because, again, sure, maybe you haven't been more than one state or two states away from where you live, but who did you have the potential of interacting with in those other locations? Yeah, and we're kind of seeing that a little bit with the spread of mumps too. Mm-hmm. And it's like, it's regionalized here. We're not going to see it. Nope. Guess what? Next report coming out, it's jumped from this county to this county, or from this state to this state, and we're a very mobile, very mobile world out there.
They keep harping on that at my institution. I'm sure it's the same as yours, because Chicago is really a center where people come from. So we always have to think that and be prepared and have that on our screening intake forms about where you could have come from, because they'll come straight to us from the airport.
And then I'll say the added challenge in transplant with all of this is, number one, we're seeing patients in the adult side who are older, who may not think about that one trip to Arizona they took 50 years ago. For Taylor and even for us, having to think about things that, you know, the patient's mother was exposed to that are, you know, Chagas, for example, certain viruses that are transmitted, and they don't know anything about that. But we also have to worry about the experience and the exposures of, you know, a patient who just passed away and is giving the gift of donation. And so that, like, is the, you know, we don't often get all of that information that we would like, and so calling something endemic really is a challenge, because where they are now is not where they were when they were potentially exposed, and so I think that definitely adds to the complexity of calling an infection endemic.
Complexity, but fun.
But fun.
That brings up another question, and again, excuse my ignorance for this, but there's also been an evolution of, you know, if you had a recipient negative, you wanted a donor negative organ, and now with the advances in therapies, that's kind of changed a little bit. You can talk about that?
Which pathogen do you want to talk about?
We've got all afternoon.
Yeah.
Definitely, I know EBV is more of a you thing, Taylor. CMV, it's definitely not, in at least adults, as much of an issue.
And then I think of HCV now.
Yeah.
Hepatitis C is something that we can enter into this conversation about.
But I will say, you know, one thing that I think is like so promising, and I was just at a lunch talk about this, you know, now we're getting so much more advanced with regards to HIV diagnosis and treatment, and we are working towards getting HIV positive to HIV positive donation across the country in all organ types. And I think, you know, if we were to have this conversation at WTC 2035, I wouldn't be surprised if we're talking about potentially HIV positive to HIV negative transplantation, and to think how that is so unheard of right now. I'm excited to talk about that in 10 years, because I think it really is a reality in my career and lifetime.
Well, I'm going to go ahead and tell my engineer Tom to put you down.
Yeah,
for
sign me up.
Transplant discussion in 10 years.
Sign me up.
Hopefully we're still here.
Yeah.
What other things have you seen, you know, here at WTC 2025, different symposiums you've attended like this that had you, you know, going, oh, that's interesting, good, or, oh, that's interesting, I'm going to have to do some research on?
There's so many. I've been inundated with just ideas, and I'm trying to take notes as fast as I can. One that I immediately wrote home about is the importance of including pediatrics in clinical trials, which I, of course, know that it's very important, because a lot of times different industry leaders will consider pediatrics just what I would consider young adults or adolescents, where as long as you have anyone 18 or maybe down to 12 pediatrics, they say that's pediatrics. But for me, I have a lot of kids, especially like our heart transplant children who have congenital heart disease, or our younger children with biliary atresia that end up getting liver transplanted quite young.
Right.
I want those trials to be done in that population, because we know the drugs are different in that group, and we need to include those groups in our trials. So there was a talk about how to improve enrollment, because enrollment's a challenge on both sides, not just having the trial done, but then getting the patients. They're few and far between. And then what do they need that is not traditionally in adults? And how do you talk to actually children about what the trial is going to be? What do they care about, and what do the parents care about? Because it's not the same as enrolling an adult patient themselves. So
you think there's a stigma associated with the exclusion of pediatrics in trials? Is it because of, they're young, they shouldn't have to worry about that? But honestly, take the blindfold off and realize that disease is spread across all age groups: pediatric, adolescent, adults, geriatrics, and I'll let you finish my thought on that.
But no, I think there's definitely a part where that we have a higher threshold for wanting to have potential risk of harm in pediatrics. We want to protect them, which is totally understandable. But then by not including them, we don't have the agents that they need to treat them. So that's harm in of itself. And so it's walking that balance. And from a pure financial and logistics standpoint, it's hard to get pediatrics in there. It's a rare population, and so it's much more cost effective to go to a large transplant center. You're just talking about how many more transplants, the adult centers do than the pediatric centers. You can enroll one center for adult and get your child, a bunch of people enrolled, and for pediatrics, you have to spread it across multiple centers. But that doesn't mean we shouldn't be including them. We might have to work harder, but we have to do it. It's not really a choice. We need to do it for those kids. We need to do it for their families because it makes such a big impact. And if we don't, we either don't have the option to use those diagnostics, those therapies, or we use them and risk even more harm because we're using them without knowledgeable dosing or side effect data.
Right. What are your thoughts on that, Daniel?
Well, I was just gonna add it. I think hard enough in general studies to get transplant patients. They're often excluded. They don't want anyone who can make data messy. And so I think I look at that too a little bit with children, where it's hard to get them involved because it's not a disease of just this one person, but it's their whole family, getting them involved. So you're having a subset of a subset that's already so challenging to get into some of our trials and inclusion criteria. So I feel for you because
Thank you.
I'm involved in some trials that are both transplant specific and not, and for the ones that are not, trying to get transplant patients in who I think would really benefit from a diagnostic test or from a medication. It's just kind of disheartening that we can't generate that data for the same reasons that you said. Trying to shield someone from harm now might actually be doing more harm than good.
Yeah.
So
well said. Very thoughtful. So, as part of this, I would believe that both of you are involved in various advocacy programs. You want to talk about which ones you work with, which ones are near and dear to your heart, and which ones you're considering getting involved with?
So with regards to my passion for fungal infections, I'm involved with the mycosis study group. I actually am a big advocate for not only patients but also for our trainees, and so I try. I think we have through the MSG and through other organizations, like to work in early career committees, trying to get early career and residents and fellows more involved in conferences, in research and dissemination. I'm involved at the university through my role as the medical director of Transplant ID and in the associate program director for infectious disease fellowships to get our fellows, help get them the training that they want, get them to the fellowships that they want. So for me, that's a big thing that I advocate for, and trying to get them the best education that they can, especially because transplant infectious diseases is not accessible to every trainee in every program. And so I try to get what I know and what I've been taught to as many people as possible. I also, as part of the MSG and part of some patient advocacy groups as well. But I do like to really harp on advocacy for trainees because I've had mentors who have really advocated for me.
Nice. Taylor?
So I mentioned earlier I am part of this transplant families group on their medical advisory committee. I also help with planning a conference that we have every year, and it's a virtual conference that we try to focus on different areas of transplantation that are of interest to both recipients but also their families. And so we cover topics for a lay audience. Surprisingly though, well not surprisingly, because I learn a lot of these things because I don't know, HLA matching still I struggle with sometimes. So I love hearing the talks, but...
And she's a double doctor, so...
So I learn a lot, and then we have them recorded so that families can understand. We had a whole series last year on what do these lab values mean. Just going through a basic complete blood count, metabolic panel, the rejection markers. What do those different things mean when they see them show up on their MyChart? So topics like that we cover. Of course, we've had to venture into, unfortunately, vaccine issues and thinking about advocating, because our transplant patients, often when they were transplanted young, they can't get their live viral vaccines. So they're not protected against measles and chickenpox and things that are unfortunately spreading again, and they are terrified of, because we can't do anything except for encourage everyone around them to get vaccinated and protect each other. Along with that, I've also been exposed to more about, just in general, the transplantation infrastructure in our country and all of the modernization, quote unquote, that's going on with OPTN and UNOS and HRSA, and that's gone over for the past year, and how that's changing and how we need to make sure that pediatrics is represented in that. Going back to, we're a small population, can easily be overlooked if we don't keep our voices loud. So although it's not necessarily infectious disease related, it's important to my patients, so it's important to me, and I try to contribute to those policy discussions as well.
Very good. We're about ready to wrap up here. If people want to get a hold of you, ask you questions or like that, do you want to share an email address or how people can get in touch with you?
Probably the easiest way for someone to get a hold of me is I can give you the infectious disease sort of clinic at University of Chicago, and that's how they get me all of my messages. So that's at 773-834-1443, and you can ask for me.
Yes, because I have a hyphenated long last name, email addresses are challenging. So
that's why, I mean, social media,
phone numbers,
like
phone numbers would be good. I'm not as active on social media as I should be. I do have Blue Sky and X accounts, but I don't keep up as I should. But the infectious disease office at Lurie Children's is 312-227-4080, and you can call them and they know how to get a hold of me. It's better than giving you my desk number, where I'm often not sitting at because I'm off in clinic or doing some other meetings like this one.
I was going to say the same thing. You don't want my academic office number.
No, that's completely understandable. Well, I thank you both for taking the time to sit down, have a open, illuminating discussion with me this afternoon. And I do have to put the standard disclaimer on there. The views expressed in the previous podcast are not those of Eurofins Viracor, which is the host of Transplant Radio, Amplify Your Voice, but it is the views and opinions expressed by our two guests today. And appreciate you guys sharing those with us, and perhaps it will cause people to step back and think about, this is the way we used to do things, how can we do something tomorrow?
And if you're in medical school or residency, go into infectious diseases.
Especially pediatrics.
Yeah.
I don't know how we lost Daniel. I'm really sad to know that. I'm glad that we still have you in transplant, though. Thank you so much for having us. Glad to have both of you,
and appreciate everything you all do. Thank you very much.
Thank you.
Thank you.
Make sure to subscribe to this podcast and follow us on social media to stay up to date on all the latest information. If you want to help spread the word, please give us a 5-star review and tell your friends and colleagues to subscribe too. We're available on Apple Podcasts, Spotify, Google, Podbean, and more. With over 40 years of diagnostic innovation and specialized expertise in infectious disease, pre- and post-transplant, allergy and immunology testing for immunocompromised and critical patients, Eurofins Viracor is committed to helping medical professionals, transplant teams, and reference labs get results faster when it matters most. Viracor is passionate about delivering value to our clients by providing timely, actionable information, never losing sight of the connection between the testing we perform and the patients you serve.